welcome everybody. This is our third year of Patient Partnership Week, which is very exciting. And this is the first webinar of the week. So thank you so much for joining. And for those of you that don't know much about the Patients Association, we are an independent charity that has been going for 61 years now, which is very exciting. And we're all around patient partnership. And today's webinar is going to be around shared decision making. So for those of you that are not too confident with what shared decision making means, that is essentially when a patient may go to the GP surgery or speak to another clinician and is really looking at that discussion between the pair of them. How do they get to a decision about the treatment that they may have to go forward? I will let each of the panelists introduce themselves. So I'm going to start with Jess. Good morning.
Hi, my name's Jess Plant. I'm a patient from County Line in Essex. I use NHS services both in primary, secondary and tertiary care, and in both mental and physical health services. I'm also a care partner and carer for my mum who lives with multiple long-term conditions. I'm a member of the Patients Association, which everyone can do. It's free to join, so if you want to join up after this, you can. And I've been involved with the Patients Association for a couple of years now. So that's me in a kind of nutshell for this.
I love that little plug for the Patients Association. Knew I could rely on you, Jess. Thank you. Al.
Morning, Sarah. Morning, everyone. Lovely to see you. I'm Alf Collins. I'm a recently appointed trustee of the Patients Association and recently retired doctor. I was a community consultant in pain management for 25, nearly 30 years. Spent quite a lot of my professional lifetime thinking about teaching others to supporting the implementation of shared decision making. For the last 8 years, I was National Clinical Director for Personalised Care in NHS England. Over to you, Sarah.
Lovely. And last but not least, Paul.
Thanks very much. Good morning, everyone. My name is Paul Grundy. By background, my clinical practice is neuro-oncology surgery, which means I see and treat patients who have brain tumours. I still manage to keep up a bit of my clinical practice, although I spend most of my life now working as Chief Medical Officer in Southampton, which is a senior leadership role. And actually, one of the privileges of working in this role is you have the ability to influence others. And actually, for a few years, I set up a program board to try and embrace and embed shared decision making across our organisation. So whilst we might not be perfect, I hope we're doing things somewhat better than we perhaps have done in the past. So thank you for inviting me.
Fabulous. So we've got three really interesting perspectives on shared decision making today. So I'm going to call on Jess first, and it'll be fantastic to hear from your perspective of both as a patient and as a carer what you think shared decision making means to you, and I guess how you found it so far. What are the, have you had positive experiences? Have you had negative experiences? What have you learned from shared decision making?
Thanks, Sarah. So I'm going to read out some kind of wants that I have from shared decision making first, and then I'll go into a little bit of, if I can, how it's worked in practice for me, because I've had both good and bad experiences, as I think probably most patients has, because it hasn't actually been kind of rolled out or implemented across the NHS yet. So these are kind of wants that I've identified as both a carer and a patient. So firstly, I think I want to be seen as an individual. What I was thinking is, I know that a doctor may have seen hundreds of people with migraines, for instance, as a neurologist or a GP. But for me, that might be the first time that I'm going to someone with a migraine. So for me, it's the first time I've ever encountered the treatments or the options. So, don't treat me as like the 50th person you've seen with migraine that week or that month. I'm an individual. And also, I want to be seen as an equal. And also, I think this is very important for carers as well, because I think carers are often left out of the discussion when shared decision making is happening. If the patient wants them to be involved, that is obviously not every patient wants their carers to be involved, but if they do, I think the carer needs to be an equal part of the decision making with the team. So obviously the health professional is an expert in their field, whether that be physio or a doctor or an OT, but the patient or the carer is an expert in their lived experience. So how that treatment might fit into their life. So for instance, it might be fine for a dietitian to suggest a certain diet plan, but if, for instance, the person doesn't have the money to go and buy what the dietitian is suggesting, then that treatment isn't going to work. So you need to come together and find a different plan. Another thing is, I want the options explained to me like I'm a general human being. So if you're talking through a complex surgery with me, or a couple of different surgical options, for instance, with me, I want the options explained to me in simple terms, not like I'm one of your junior doctors. I want the risks and benefits explained to me, how they would impact my life, not how they might impact how you would talk to one of your colleagues, because that doesn't actually explain to me what the impact is going to happen on my life. And another thing is, I want to feel listened, valued, and not judged when I'm discussing the options with you. And what I mean by that is, something that might matter to me might not matter to you. So for instance, I might want to go fishing twice a week. So it might be really important to me that I have a certain movement in my elbow, for instance, because that might enable me to go fishing. But you might think that really doesn't matter. So you might think that a certain loss of function in my elbow might be worth it. Or you might not think my pain's that important. But actually, for me, that might be the one thing that makes my life worth living at that moment. So that might be really key to my mental health and actually to the quality of life overall. And then kind of finally, I want to feel, and this is kind of an overall point, I want to feel part of the treatment plan and the investigation plan moving forward. And this also is that I want to be able to feel that I can come back to you and discuss the options if they're not right for me in the future. So, and I think this is probably more important in kind of primary care and maybe in secondary care if you're discussing kind of drug treatment or the kind of surgical options that might have a more long-term effect. So say you're trialing a drug, if it finds that it doesn't work, I need to be able to feel that I can come back to you or come back to the surgery to say, actually, we've tried this, but actually it didn't work. So the benefits or the risks that you outlined actually did happen to me. So we need to try something else. So they're the kind of things that are important to me that I think that are important to a lot of patients, that clinicians and patients need to think about when they're kind of going to discuss shared decision making with clinicians. Also, talking just a little bit about my personal experience, I think shared decision making, I've had good and bad experiences. I've had experiences with doctors I have a good relationship with my GP, so I think my GP and good relationships, I think, can be a really good foundation for shared decision making. I think, particularly in primary care, I think that if you have a good GP, you're very lucky, and that can be a good relationship. And I feel that shared decision making on the whole works with my GP. I think in secondary care, the time pressure can be, particularly on a ward, it can be a bit kind of time pressure. You may not actually see the same consultant every day. But saying that, with my mum, who's been in and out of hospital recently, I've had some really good shared decision making with my mum. She won't mind me saying this, I've asked her before. We've actually discussed kind of complex situations and had really good discussions involving not just doctors, but people like speech and language therapists, where we've come to kind of difficult decisions. They've outlined the options, and we've kind of all worked together as a family and actually weighed out the options and kind of come to the best decision for my mum, for us as a family, and for what she wants. Because actually, what might be the best medical treatment, and I say this like, what might be like the best intervention. So I'll give a specific example. So in this example, it was a nasogastric tube. My mum couldn't eat at this time, or she had a difficult swallow. They were concerned about her swallow. They wanted to fit, or were thinking about fitting in a nasogastric tube, and she just wouldn't tolerate it. She just didn't like it. So they actually decided for her quality of life, they would actually just try it without a nasogastric tube and take the risk, because that her quality of life was actually more important. And she understood the risk. We all understood the risks. And actually, that was her decision, and the quality of life was the most important thing. And actually, we all decided that, yes, that was the most important thing. So although the medical intervention would have maybe erred on the side of, yes, let's go gun-ho for a nasogastric tube, this was what kind of in the textbook, you know, if you have a difficult swallow, maybe nasogastric tube would have been the right intervention. It wasn't for her. And I think that's the kind of discussion that needs to be had. But then on the other hand, I've also had kind of bad instances where you kind of say to someone where you don't feel listened, where you're kind of talking to them and say, well, maybe I would like to try this tablet. And they say, well, no, you can't have it. You're going to have this one. Or you say, this one's giving me side effects, but they still say kind of still progress with it. And then you go back a few months later having suffered the side effects, and then they change it. So you get the feeling they're not being listened to you. So it does depend a bit on the clinician. But then also, it's not just on the clinician, I don't think. I think that patients also have a role. And I think patients and carers can educate themselves on what they can do when they go and talk to a clinician. And this, if I've got time, Sarah, just to go into
yeah, I can listen to you all day, Jess. So, and I think everyone else can. So please go on. Yeah.
Okay. I was just going to, I think patients and carers can educate themselves a little bit on what to do if they are preparing for an appointment, which might help with shared decision making. And I use a tool called BRAN, BRAN, BRAN. There are other tools, but other tools don't work for me because I can't remember them. So BRAN it stands for benefits, risks, alternatives, and nothing. So if I go through it, it just allows you. So obviously you can write down what you're going to the doctors with, but then you can ask them if they suggest something, and it can be an investigation, it could be a treatment. You can say, what are the benefits of this treatment? And then what are the risks of them? Because each treatment will have a risk, and it's up to you whether that risk fits into your lifestyle. So it could be nausea, and you think, okay, nausea is okay. It could be, for instance, a more serious risk, hair loss, for instance. Now, for some people, hair loss is a really serious risk, and I totally understand that. But for me, I don't particularly like my hair, so hair loss would be okay for me. Not a particularly big risk for me. But for lots of people, hair loss would be really, really serious and a really big mental health risk to them, and would really affect their self-esteem and their body image. So that would be a really big risk. Alternatives. Now, for most things, maybe perhaps everything, there is an alternative. Now, for some things, alternatives, that would be doing nothing. And the alternative may perhaps lead to, unfortunately, a really poor outcome, and including death. But there is an alternative. You search for it. It's just whether you can put up with the alternative. So that's the benefits, risk, alternatives. And then, as I said, nothing. You can always choose to do nothing, and that includes the investigations. Not everything has to be investigated. You could have a lump, for instance. You don't have to have it investigated, but the risk of not having it investigated, if the doctor recommends it, is that you could be missing something serious and that it could spread. So perhaps the anxiety of having it investigated is worth the risk of the anxiety, because you might catch the potential nasty earlier and be able to get it treated. So they're the things that you can discuss with the doctor or the speech and language therapist or the physio. So that's what I think. So it's not all up to the clinician or the doctor or the physio. I think that patients and carers can do things and can be educated to do things that can make the consultation better for them. Because that's what I believe. I think that going to the doctor is not just about going to see the doctor. It's actually about two-way communication. It's about what you communicate to the doctor as well. It's not about just what they or he or she communicate to you. It's also about what you communicate to them and the discussion that happens in between. So yeah, that's what I think. Oh, that's my part. If that's
I
okay,
think
Sarah?
that is wonderful. And I just want to read out, I don't normally do this in the middle, but I want to read out a comment that someone has written. When you said, can I continue? And I said, oh, please, people can listen to you for ages. Someone's put, you are absolutely right, Jess. We understand that clinicians are seeing multiple patients every day, but we want to be listened to, treated as individuals, and expertise on our body and the condition and medication affect us are taken seriously. And other people are saying, yeah, well put together, Jess. So thank you so much for that. And I don't know how you're going to follow on from that, Alf, because Jess has probably said everything that you want to say because it was so fantastically eloquent. But I'll go over to you now, Alf, from a kind of a system perspective and thinking about hearing all of that, you know, what can organizations aspire to do, and how well are people doing? Is this something that can really happen?
A few things come to mind. First off, Jess, thanks. That was fantastic. And I'm sure, just as you say, Sarah, Paul and I are going to say very, very similar things to Jess, but from obviously clearly slightly different perspectives. First off, what I just a little anecdote from me. About 7 or 8 years ago, I'm pretty fit generally. 7 or 8 years ago, went to bed on a Sunday night, probably had one glass of wine, no more. And suddenly my heart started racing incredibly fast. I felt faint and I lay down. I thought, oh, go away. And it didn't. So I lay there in what's called fast atrial fibrillation for about an hour before I called the ambulance, thinking I had a heart attack. Anyway, to cut a long story short, I hadn't had a heart attack. And at about 3 o'clock in the morning in casualty, the consultant came along, not met him before. I'd seen the registrar, and the consultant said, we have a choice. But you know what? It was one of the most reassuring phrases I've ever heard in my life, that he was handing over, or he was sharing with me the responsibility for making a decision. So my personal experience just from that one episode was how incredibly comforting it was to have somebody say, we have a choice. Just 4 words. Anyway, look. I think that what's happened over the last 20 years, because I've been interested in this for about 20 odd years, is that conversations have moved from why should we do this to how can we do this in the health system. And a lot of people now are trying to figure out, people in the health system, just how to implement shared decision making. You'd love to think it was just straightforward. You'd love to think that we're all pretty kind, those of us who work in the health system. We've gone into it for a really good reason, and you'd love to think that naturally we'd have shared decision-making conversations. And no doubt some of us do. That consultant in Taunton Hospital 7 or 8 years ago that I saw, just naturally did it. It was brilliant, absolutely brilliant. none of us, not all of us are like that, and many of us do need a bit of training. And I think that's particularly because most healthcare professionals, and I think doctors in particular, are trained to be decision makers. So you're trained to make a diagnosis. You're trained to, based on what you know of the evidence and what you know of the patient, to come up with a decision about the right treatment for them. And certainly those of us who were trained, 10, 20, 30, 40 years ago, it wasn't part of our training at all to share decisions. So we're asking clinicians to do something very different to the way, often very different to the way that they were trained, and often very different to the way they've habitually practiced over the last 3, 5, 7, 10, 20 years. So there's it's not because they're bad people, it's because that's the way they've been trained. And actually, here's me, having come from NHS England, quite a lot of healthcare policy drives clinicians to actually act in that way. So there's something there. There's something about training for clinicians that's really quite important. There's something, just as Jess has said, about making sure that people are prepared, and Brand's a great example. There's a number of examples. Another one's called Ask 3 Questions, which I know, Paul, you use in Southampton, but a systematic way of making sure that patients are prepared. I think probably one of the most important pieces is a supportive system. So trained teams, prepared patients, a supportive system. So, at the level of a team, are we doing everything we can to make sure we do this reliably and really well with everybody we see? Have we been trained? Have we got, whatever prompts that we might want to use, Ask 3 Questions or Brand sent out on clinic letters? They're in waiting rooms. They're on your screen if you're having a virtual conversation before you have the conversation. So are we reliably and systematically doing that? But also what we know is that the culture of an organisation, so that could be a primary care trust, it could be a hospital trust like Paul's, it could be a integrated care system. The culture of the system comes from the leadership. Are the leadership explicitly taking this seriously? And Paul and I have just written something together where we looked at some of the evidence behind this, and we probably should be doing more at a systems level to encourage and support these conversations to take place. I would love to think that we are moving in the right direction. I'd love to think that the kind of data is better than it is. The data is not that great. We know that shared decision making is a process. We know that it's a series of conversations. We know that the core elements of those conversations are talking in plain English, just as Jess said. More than 4 in 10 people currently don't understand clinical information as we currently relay it. That's a pretty damning fact in itself. So speaking in plain English, helping people understand their diagnosis, helping people understand the treatment options and what's known of the benefits and the harms and the uncertainties, including doing nothing. Supporting them to tell their story and to become involved in the conversation so that we start to together think about what really matters to them in order to come to a joint decision. If you kind of look at each of those elements, it's probably only happening in about 4 in 10 conversations, really, perhaps 3 in 10 in healthcare at the moment. So we've got a way to go. We're in a better place than we were certainly when I started thinking about this 20 odd years ago. And it's thanks to beacons like Paul and his team and lots of other people that it's clear that, nationally we are moving forward. There's still more work to be done. Sarah, back to you.
Thank you. And I jotted down a few things that really stood out for me there. When you said about we have the choice, there's 2 big words there, isn't there? We, to show that, there is a partnership there and that there is a choice potentially with that care. And also that training is relatively, in the big scheme of things, quite new around shared decision making, which is, I guess, a bit worrying, but I guess, times change, don't they? And then the last one is around how important the culture of an organisation or a system is, and seeing that leadership really implementing shared decision making and how that kind of trickles down amongst other clinicians and other staff members. So thank you for that, Alf. And then last but not least, I'm going to hand over to Paul, who, as we've said, is actually a neurosurgeon and medical director, so is with patients daily. Well, I assume daily, but I don't know. So it'd be really fantastic to hear your perspective from that real on the ground clinical perspective.
Yeah, thank you very much. And I thought what I'd do is just say a few words about what shared decision making means to me. Now, Jess has really covered this so clearly, and Alf has followed that up. It's kind of hard, but I guess I have a sentence in mind as how I define it, and I'll explain what that is, and I'll talk through 3 patients that have stuck in my mind. 3 patients, and the reason I talk through these 3 patients over my career here as a brain tumor surgeon is that I've been able to reflect and be quite self-critical and appreciate and realize moments when I didn't get this right for my patients, and that has been very helpful. And that really follows on from what Jez was saying. We don't always get this right, and there is a journey we're on. And Alf explained some of the background to that. That for many of my peers and senior colleagues, this isn't the way that we were brought up and taught to work with patients. And the other thing I would comment at this moment in time, because I spent a lot of time talking to people about what shared decision making is, and when I talk to my clinical colleagues about this, they all tell me without fail that they all do this exceptionally well. And we all know that isn't true. I know that because I've been very self-critical and reflective. And what I suggest, by the way, that I ask those clinicians to do is ask their patients how well they have those conversations. There are scoring systems you can use, and that's quite eye-opening, and I've done that myself. So what does it mean to me? Well, the definition I have in mind is that this is an honest conversation about reasonable competing options. And just want to unpick that because it gives you many areas where this can go wrong. So there is the honesty piece at first. And what do I mean by honesty? Well, I'm a brain tumor surgeon. I have the privilege of looking after patients who unfortunately find themselves in a very difficult place. Often they've just been diagnosed with a brain tumor, and sadly, the most common tumors I see are malignant, incurable brain tumors. So there are some very difficult decisions for those patients to make. And when I mean honest with patients, there are degrees of honesty. And I guess one of the things that I've learned with time, and I'll explain that with some of these examples, is that I think it's better, however difficult it is as a clinician, to be very honest with your patients. And actually, one of the things you can do, by the way, at the start of a conversation is ask patients or warn them that you're going to have a difficult conversation. And almost without fail, people will say, I want you to be honest with me. I want to know the truth. I want to know what the reality is. I don't want you to, soften the blow by, So I think on the whole, and you've got to talk to patients and find out how they want to frame these conversations. But most patients do value that honesty. And in actual fact, without that honesty, I think it's very difficult for patients to make an informed decision about how they go forward. And so it's a difficult thing to do. People don't like doing it as clinicians, but I think it's really important for your patients. The second thing is that this is a conversation, and just touched on this as well. But when I talk about it being a conversation, I mean, this isn't just a clinician who's entered this room with all of that knowledge of the diagnosis and the prognosis and the treatment options, but there are 2 experts in that room, aren't there? And the second expert is, of course, the patient and or their carers, relatives and family that come with them. And they are the expert in themselves. And without you exploring what are their views, preferences, values, beliefs, Jez mentioned a lot of this before, without you asking them those questions, how can you possibly guide them to what might be the best option for them? So this isn't just, as some of my colleagues believe, a clinician giving people a list of options. Here's your options. There are 5 options. Go away and think about it and tell me what's the right thing to do. This is a conversation, a 2-way process where you explore what matters most to your patient and try and work out with them and for them which one of those options might work best for them. And that isn't, of course, always the option that we think as clinicians is the best option for them. And that's something I've struggled with in the past, but have come to terms with. And the final thing, I won't say much about this, it is about reasonable options. So it's not about offering things that you don't believe are possible or feasible or sensible. It is about reasonable options. And if I then reflect back, as I have done, I spent some time doing, because and we talked about training. I went and had some training with Alf and the team in NHS England in about 2016, I think. And at that point, I'll be honest, I was one of those somewhat arrogant clinicians who thought I already do this really well. I get good feedback from my patients. I have a good conversation. I always give them options. I always give them options of doing nothing, for example, which is one of those things that not everyone always did. So I was quite proud of the fact that I did this very well. Until I went away and learned about shared decision making, which I didn't really understand, if I'm honest. I thought I did, but I didn't. And that changed the way I spoke to patients. So if I go back, I've been a consultant now for nearly 20 years here, and I'll give you 3 examples of patients all had the same diagnosis. They all had a malignant, incurable brain tumor called a glioblastoma. And sadly, tragically, those tumors come with a very poor prognosis, even when you treat patients with everything that you've got to offer: surgery, radiotherapy, chemotherapy, everything. That sadly, even in that context, most of the patients I meet only live for about 15 or 18 months on average. There's a big range, but that's the average. And obviously, by the way, those are important facts, aren't they, for a patient to be aware of if they're to decide which option they want to go with, bearing in mind all the risks and things I have to talk about. But about 18 years ago, I'd been in practice for 2 years, and every patient I saw, I told them, I've seen your scan. I think you've got a high-grade brain tumor of some sort. After all, that was an honest thing to say. It may not have been the full truth, but it was honest. And I think, our MDT has discussed your case, and we believe the best treatment for you is having a big operation, a craniotomy, to remove this tumor, and we'll follow that up with some chemotherapy and radiotherapy. And these are the consequences and risks, but that is the option that's recommended, by NICE or by our MDT. It's the best option for you. I would always follow that up by saying there are some other options, and those other options might be just doing a biopsy or might be not offering any treatment at all. But to be honest, those options are a bit hopeless. And lo and behold, when presented in that way, you're getting the idea that conversation is quite a biased conversation, with basically me telling the patient what I thought was the best option. Because I know that, because I've read it in journals and publications, and they tell me that that's the best option for patients. But much to my surprise, or perhaps not to my surprise, every single patient I had that conversation with for the first 2 years of my practice had a big operation, had chemotherapy and radiotherapy, until one day, I only thought about this after I'd been trained in SDM, and this patient obviously stuck in my mind. So about 18 years ago, I met a gentleman who's about 60 with a glioblastoma. I offered him, recommended to him, might be a better phrase, that he had surgery first for his operable tumor. I did then mention the other options as I discussed, and at the end of the conversation, he said, well, thank you very much. I'll go with the final option, which is to have no treatment. And I was quite taken aback. I thought, something not quite right with this guy. He's not understood me, or I don't know, how can I explain this? And he said, look, Mr. Grundy, I've got my tax return to do. It's towards the end of the year. I'm a busy man, got a business to run. I feel perfectly well. I've got no symptoms. I don't want any treatment. So off he went, and I felt quite disturbed. I looked at my nurse specialist who was sat by me. We both sort of recognized and said, this isn't right. He can't, he's not made a sensible decision here. So I did something that I don't often do. The next day I phoned him at home just to check in that he understood what I told him. So I absolutely understand what you're saying. I am actually sitting here at home doing my tax return. I thought, this guy's crazy. All he can do is talk about his tax return. I haven't got through to him. So I phoned his GP, and his GP went and saw him. And his GP then called me back. And then I guess this is when the penny dropped, sort of partly, albeit it took years for me to change my practice. What his GP said is, what you don't understand, Mr. Grundy, is 2 things. This chap is running a business. He lives alone. And what he's doing is he's getting his affairs in order. He's trying to sort out his business, his tax return. It's more than that. He realizes he's got an incurable diagnosis. He doesn't want to take the risk of a big operation, which might mean he hasn't got time to get his affairs in order. And furthermore, the other thing I hadn't appreciated, because I didn't ask him about his own experiences, were his father had had a terrible journey through cancer treatment. And he saw radiotherapy and surgery as being this terrible thing because his father had had complications. And So he had those very strong beliefs and feelings from what he'd experienced in the past. That wasn't something that he wanted for himself. Now, in actual fact, that's a very rational decision that he'd made, and I'm sure absolutely the right and the best thing for him. But I struggled to come to terms with that at the time. I then went away and had some training about 10 years after that time with Alf, as I mentioned before, and other people in the team. I started to talk to my patients in a different way. And I did this before I'd actually trained the rest of my teams. There's something here about learning and training the whole team. And we always sit in our meetings with a nurse specialist. And I had a patient who came with his wife. I remember him well. He was in his 60s. He'd retired. He had a dog. He lived on the Isle of Wight. He enjoyed walking his dog. And I went through the options with him. But on this occasion, I did things differently, as I now practice. I was honest with him. I did tell him what I thought it was. I thought this was a glioblastoma. I did then, as he asked me to, was very honest with him about what the prognosis might be with and without treatment and what the options might be. I've changed the order of sequence of events so that I'm not having a biased conversation. I'll say, well, the first perfectly reasonable option might be to continue the medical treatment that you're on at the moment that is keeping you completely well, and we can support you and control your symptoms. Or we could do a biopsy, or we could do a big operation, and these are the pros and cons. Not giving any frame that I thought one was better than the other, just different. And he said, well, thank you very much. I don't think I have any treatment. I'm fine at the moment. I'll enjoy the quality time that I've got. I don't like being in hospitals. I don't want to have a big operation. I don't want to lose my hair, all those things. So now, obviously, at this point, I felt quite comfortable that he'd made the right decision for himself. Absolutely, I was able to support him. But when he walked out of the room, and by the way, we were asking patients to fill in a questionnaire at that time on the quality of our shared decision-making conversations. And I can tell you he scored us 27 out of 27, which is that he was very happy that we'd had a good conversation. He knew exactly why he was making a decision, etc. But when he walked out of the room, my clinical nurse specialist turned to me and said, oh my goodness, this guy doesn't get it. He's crazy. He needs an operation. You need to go and tell him, go and get him and tell him he needs a big operation. I said, I think, we had a conversation about how we'd been through it all and so forth. But she was suffering the same distress as I suffered the occasion before. So we then spend a bit of time anyway, training the whole team up. And that's back to you do need some training in this, I think. And it is everyone. This is a team sport. It's not just about individuals. Everyone needs the skills, but it is a team. And we then had another very memorable patient that had come after, I think it's fair to say we properly embedded this in our service. So that's the whole team, including my trainees and others. And so about 5 years ago now, we had a very unfortunate gentleman who, again, had a glioblastoma. But when he attended the clinic, he had quite a significant weakness down one side. And he was a young chap. He was only 36. And he was a really fit guy. And my fellow had a chat with him and said, well, what are the things that are important to you in your life? And he was quite a handsome, muscular guy. And he said, well, look, I work as it's just been festival season, hasn't it? So he works in festivals. He was a security guard. And he sort of proudly told my fellow, I quite love my work. I love the music. I like being around people. And the other thing he confessed was he said, I'm a bit of a ladies' man, basically. I don't think he said it quite like that, but he quite enjoyed the success with the ladies that being a security at the festivals gave him. His other passion was weightlifting, bodybuilding. He was a real gym bunny. He loved his time in the gym, so he was a really buff, muscular guy. And his final passion was he liked motorsport. So he had a car that he spent a lot of money doing up, this car, a sort of sports car that he raced occasionally. And his question back to my fellow was, will I be able to do my job again as a security guard? Will I be able to go to the gym again? And will I be able to drive or race my car again? And unfortunately, the answer to all of those questions was no. You're not allowed to drive. He had a weakness that we didn't think we could recover. So whilst we could have treated him, he said, well, that, in a sense, those are the things that give me my quality of life. And if I can't do those things again, why would I go through all of this horrendous treatment that you're talking to me about that's offered to me just to give me a few more lives, living my life, not being able to do the things that I love and I live for? But on that occasion, of course, he's got my fellow, he's got me, he's got the whole team supporting him, absolutely accepting that he's made the right decision for him, even though perhaps if we're sat in our meeting without him being present, we might have made a different decision on his behalf. So hopefully that gives you a bit of a few examples really of where I've got it wrong in the past, where as a team we're doing it better. But I would say there is a lot more to be done. I know Jess has described mixed experiences in the NHS. I think that is still the case. It's a bit of a shame because as a surgeon, when I'm counselling people for surgery, obviously informed consent is something that's now very clear, that shared decision making is legally mandated as part of consent. Yet I know full well that as clinicians and surgeons, we don't get this right at the moment. And if we don't get it right, actually from a legal perspective, you're in a very tight spot actually. So it is mandated. We do think we do it really well. We don't do it as well as we could or should. I'm not arrogant enough anymore to think that I do it as well as I could or should. And I'm still learning, and I actually work with patient organisations and charities to ask them questions. What could I do differently or better to improve myself and my own conversations? So more to be done. Hopefully that gives you a bit of a clinical spin on this. Thank you.
Yeah, no, it was really interesting to hear from that perspective, and especially to hear someone say, you know, I haven't got it right every time. And I think it's good to hear from those times when maybe it didn't go as well, so that people can know how to kind of improve on that. I've got a few thoughts and questions, but I just wanted to hand over to Jess or Alf. Is there anything that you would like to ask or raise whilst we're here after listening to all of you speak? No. Okay.
No. We've said so much, and there's so much in the chat.
There is a lot in the chat.
Yeah.
So I haven't been able to keep my eye on the one in the chat, but I'm looking at what's happening in the Q&A, where all the questions are. And one of the questions actually that's come up that I'm not sure how much any of you have talked about so far is about data. So how do we know we're doing better with shared decision making? Do we need to be looking at data? What data would this be? How would you like data to be improved? What could help with looking at data in terms of shared decision making? And Alf, hand up straight away.
Yeah, I mean, there's a whole spectrum of decisions, right? Some of them are, you know, going to a primary care team and saying, I've got a bit of a cold, can I have some antibiotics, kind of decisions. At the other end of that spectrum, I guess, is kind of these kind of high stakes decisions that Paul's involved in. And of course, there's different degrees to which those decisions can be informed by data. So that's the first point. There's a whole spectrum. Yeah, what I would say is that particularly moving into kind of hospital treatments and surgery, we should be using the data a lot more, frankly. There's a lot of data around. We're not good at either sharing it with patients or frankly understanding it ourselves as clinicians. And I think this is probably where decision support tools come in, and we created some decision support tools when I was in NHS England. I think it's one place where there's a lot more work to be done. I'm sure Paul's got something extra to say.
Yeah, only to come in, I hinted at this before. I think what's really useful live data to me is something that you can use as clinicians. There are some really simple scoring tools. We used to use something called Collaborate, just has 3 questions. We now use something called SDMQ9, and that's 9 questions basically. So very simple questions about the quality of your conversation. And the useful thing about that for me, and I mentioned this before, is as a clinician, you can fill out a clinician SDMQ9 for your consultation. You can ask your patient to do it. And it's interesting to compare notes. And what I can tell you, and it's no surprise in this, is that the clinicians consistently score themselves more highly than the patients score the quality of those conversations. And not always in every domain. So they've got different domains in that question. So why I think that's useful for an individual is you'll learn, oh, there's opportunities for me to improve, but you might realize it's in domain, I won't say, 7 or 8. This is the bit that I'm not doing as well as I thought. But for me, that sort of live data that comes through gives you a real picture of how well you're having these conversations as a clinician. And we've done that across whole services and allowed us to improve, and in fact publish some work on that. So I think that kind of live data is really useful, because this is all about self-improvement, isn't it? To create a better experience for our patients.
Yeah. Anyone else before I move on to another theme? Because this has come up in the Q&A, which is an interesting one. So the question is around training and pharmacists. So obviously pharma, like either internally in a hospital or in the community pharmacist, they have a lot of power nowadays with speaking to patients on a regular basis. So I guess one is, do you know if pharmacists get training in shared decision making? And two, kind of where do you see the role of shared decision making with pharmacists? And that's for any of you. And Jess, I don't know if you ever go to the pharmacist, and actually, yeah, it might be good from a patient perspective if you were going to go to a pharmacist. How would you see shared decision making?
Yeah, I'll come in on that. I don't know if they receive any training on it. I don't know if Alf or Paul would know that, but I don't see it really as any different from anyone else in the health professions, because I think obviously at the counter it can be difficult to do shared decision making, perhaps because you don't want to necessarily share all your details at the counter. But pharmacists are required to have a consultation room. So I think if you actually have a consult with the pharmacist, I don't see why you can't use the shared decision making tools like Fran in the consultation room. So I know they have like 9 conditions now where you can go to the pharmacy first, like ear infection or insect bites, or don't quote me on that. I'm not a clinician, so don't quote me on what conditions they actually do, but minor conditions you go to. But I think you can use shared decision making from that in the pharmacy consultation room. So yeah, I don't see that any different.
Alf.
Yeah, I think a few pieces come to mind. There is nice guidance on decision making and adherence in medicines management. It's about 12 years old, and it is really clear, and the evidence is really clear, that if we have shared decision making conversations with people and they decide to go on to a medicine, they're more likely to stick with the medicine if they shared a decision about it. And adherence levels are around 50%. So about 50% of medicines aren't taken as described. So you're more likely to take them as prescribed if you've shared a decision about them. Second piece is the Centre for Postgraduate Pharmacy Education, CPPE at Manchester University, does have courses on shared decision making, so they are available. The degree to which pharmacists are undertaking them, I don't know.
Fab. Another theme that I'm seeing coming up is around time for clinicians. So the clinicians might say, well, I don't do shared decision making because I don't have time. I'm just going to leave that statement with you for all of you to respond how you wish. Paul, straight in there.
Yeah, and I think, and it's something Alf and I have discussed before, I think there is some evidence that to do shared decision making effectively probably does take a bit longer. And my approach to that in my own practice, and I described those clinics, how they've changed. What I didn't say was that I increased the length of my first outpatient appointment with patients from 40 minutes to 50 minutes. And that's so that we could have a better quality conversation. But I would say that 10 minutes extra pays off more than 10 minutes back in terms of, first of all, patients making the right decision that works best for them. And of course, for some of those patients, as I explained, that might mean the option of choosing not to have any treatment at all. Because you always get this debate in hospitals, don't we? At the moment, there's a lot of pressure on finances and money and workforce, and we must do more and more work and be more productive. But the other thing I've noticed is if you do have a really high quality conversation up front, then there's less need quite often for a follow-up conversation. And in fact, the one thing I've noticed with our brain tumor patients is that actually the most difficult conversation for us used to be when they came back for their results, a week or so after surgery, and we had to explain to them what the actual diagnosis was, even though we knew that from the outset, as I hinted. Those conversations are now 100 times easier because we've had a really good conversation. We've informed our patients, worked with them. They know what to expect. And actually, in a sense, we saved a bit of time there. So I think it probably does take a little bit of time, but the better you get at it, the more you just apply it to your everyday practice. And actually, you probably end up in a place where it doesn't really take you that much longer. But there are so many other benefits that little bit of extra time pays itself back.
Yeah, perfect. Alf.
I can come in, but what I don't want to do is just to have two middle-aged doctors talking and Jess not having a say. Jess, is there anything you wanted to say before me?
No, not really. Well, not from like direct experience, but just if you think about it rationally, even as a patient, adding to what you said, Alf, I think that getting it right, there's a whole thing about getting it right first time, isn't it? The right decision. So even what you said about medication adherence. So even if like getting someone to take medication adherence to antihypertensive is notoriously low because people don't recognize the benefits of them. But if you can explain the benefits of them and actually get people to take them right the first time, even if that takes 5 minutes extra, the long-term benefits to the NHS savings going forward is much better, even if that takes 5 minutes longer on a GP appointment. But I think it's getting the NHS to recognise that systemically by adding time to GP appointments, which I think in the funding atmosphere is kind of difficult to do.
Isn't it? I think you're right, Jess. I just, the evidence is actually it's pretty equivocal, actually. And but if we see shared decision making as a process rather than as an event, and if we make sure that we're systematically doing it and we're trained, the evidence is it's pretty equivocal as to whether it does take that much more time, about 7% more time in one big review. I think the other piece is this is an ethical, professional and clinical legal standard. We got to make time to do it well. We just have. Yeah. Back to you, Sarah.
Fabulous. I'm just looking at the time. So we've got 4 minutes left. I'm going to quickly summarize some of the key points that I've heard, but then I'm going to come back to the three of you after that. So some of the things that are really coming up today from the three of you is that it's all around personalised care and how can clinicians make the patient's life better? Well, and how can the patient make the patient's life better? And there is a lot of learning that still needs to be done. And this is both from the clinicians and the patients. As Jeff said, it might not be for all patients, because some patients may want the clinician to make the decision, but patients can educate themselves if they want to be a partner. There's a lot of culture that needs to be changed. In the long run, yes, one appointment may take a little bit longer, but it means that the patient isn't constantly coming back to the clinician or the pharmacist. And so, yeah, it's saving time and the patient is the expert. So that we've got 3 more minutes to go. I guess is what from each of you, maybe a couple of points on what can, and this can be a clinician or a patient, what can people be doing to make shared decision making easier? Yeah, easier, and make sure that it's actually taking place. It's quite a broad question, but I just thought with so little time to go, I'm going to make it quite a broad one. So Alf first.
So I think there's something for us as professionals knowing that, or realizing that these ways of working kind of reconnect us with our core professional values. Frankly, it's why we came into healthcare in the first place, really. And sometimes some of us feel a little bit unmoored from our professional values. So there's something about reflecting on that as a clinician. And then again, one of the things that I often do in training is saying to people, there's something about introspecting, something about reflecting on the fact that we do tend to make decisions for people because that's what we've been trained to do. And it's a habit we've slipped into. Just notice when you're doing that. Just notice. It's a starting place.
Perfect. Paul.
Yeah, thanks. I there's a few parts to this, aren't there? I think from a patient empowerment perspective, that's the number one most powerful thing. In fact, the first thing that we did here was try and promote this. We use our 3 questions, as Alf mentioned before, but that's a bit like the brand that Jess mentioned, and that is, what are my options? What are the pros and cons of each option, and what is the support I will receive to help me make a decision? And we actually tried to promote that across the whole hospital, because I kind of felt if we empowered our patients to have those styles of conversations with my colleagues across the organisation, in a sense, you're forced into acting in a shared decision-making way. So I think there's something about that. So we have posters all around the hospital. We have lift wraps saying shared, our 3 questions, and some nice pictures and some support. We've built it into our electronic documentation, where we have an electronic patient record here with our patients on pathways as well. So something about having prepared patients that I think is really powerful. But for my clinical colleagues in the hospital, and this is elsewhere, is we need to improve the training opportunity. So we've done a lot of work on improving training. We've got some virtual training available to people. I say we've got tools that we've used to try and be self-critical, those scoring systems and so forth. But that is really important. And then we've got to set up the systems, haven't we, and the support in the organisation, and also ensure we're commissioning services appropriately that align with that. So that's what we've been trying to do here as an organisation to move this forward, is look at it from various different angles about all of that working together to try and implement shared decision making more effectively. But I don't know if that's helpful, but that's the way I've thought about it.
No, that's great. And Jess, we started with you, so we will end with you.
I think it's important to prepare for your appointment. Use the tools that are available. So prepare, think about what you want from the appointment. Bring a carer if you want them to be involved, but also be willing to listen, because the outcome that you want may not be available. So also, as Paul says, think the outcome you want may not be reasonable or available. So it is a conversation as well. That's what I'd say.
Perfect. And we've run over by 1 minute, so I will need to end this now, but thank you so much to the 3 of you. There's just been like a wealth of experience and information that we've discussed today, and I think it's been fantastic. So thank you so much to Jess, Alf and Paul.